And in this conversation, we will be talking about pain. And we will be talking about pain because it is very, very little understood. Is pain in our head? Is pain in our cells? Is pain in our body? How do we even measure pain? We really do not have good answers to any of these. However, there are experts who are looking into this. And we have gotten two such experts with us today. We have Dr. Arnab Barik, who's joining us from Bangalore's Indian Institute of Science. And we have Dr. Vimee Bindra, who is from the city and is founder of an organization called Endometriosis Foundation. The reason we have brought them together is because Arnab will talk about the science of pain, and Vimee will touch upon how pain affects one class of people called women in society, and often their pain goes unnoticed, untalked about. And bringing them together will be Dr. Ponnari Gottipati, who is a fellow of Women Lift Health and is on this mission of trying to understand all aspects of women health, and especially the ones that are not very much talked about. Pain is one of them today. Ponnari, all over to you. Vimee and Arnab, please join us on stage.
Thank you so much, Somdata, for that introduction. Hello, everyone. Welcome to this conversation on pain, one of the most universal human experiences. But have you ever wondered if our experience of pain is uniform? Is how you experience pain the same as how I experience it? So we often think of pain as a signal from our body. You know, something hurts because something is damaged. But pain doesn't always work like that. Some pain lingers long after injury is healed. Some pain is severe, though the scans look normal. And some emotional pain could be more visceral than any physical injury. And while some pain is taken seriously, believed, and treated, some pain, unfortunately, is doubted and dismissed. And some of us, especially women, pain is not just something we endure, it is also something we have to constantly prove. And this I very much relate to, having lived with chronic pain for more than a decade now. So today we are asking some questions. We are trying to understand if men and women handle pain differently, and what actually shapes our experience of pain. Is it more the biology? Is it our mind? Or is it how society responds to it? And we are also trying to understand what happens when pain is repeatedly dismissed and ignored. And we have an excellent panel here today. Arnab, who's a neuroscientist who studies the neurobiology of pain and its interplay with anxiety. And Vimee, who's a gynecologist and founder of Endometriosis Foundation of India, who brings insights into how chronic pain and its dismissal can affect lives. So welcome both. And I think we'll start with some very basic questions. So when we say pain, what do we actually mean? Like I said, is it just a signal from the body, or is it an experience that our brain actively shapes? Arnab, if I can ask you to very briefly walk us through what happens from the minute there is an injury to when we say, oh God, it hurts.
It's fine. Yeah, so it's a game of thresholds. What do you mean by that? So when you just touch something or get touched by something in your environment, it can be innocuous or noxious, which means that innocuous means something that doesn't trouble you at all, and noxious means it can cause a painful stimuli, or it's a painful stimuli. So what happens is that our skin as well as the interior organs are innervated by, or there are nerve endings inside all of these organs, which can sense this stimuli, whatever you're touching around you. And if it crosses certain threshold, like say a pinprick, and it transmits information from the skin, which is your periphery, to the spinal cord, and then the spinal cord will relay that information to the different parts of your brain. And it now, given the experience, etc., you perceive that pain, which means like, it hurts. And also you perceive that pain and associate with something else, which has caused the hurt. And why is it important? Because it serves as a basic alarm function. It tells you that something can hurt you or cause injuries, and you shouldn't expose yourself to them. Often, you shouldn't expose yourself to them, and if you do often, it can cause irreparable damage or injuries, right? And what happens in chronic pain, for which you go to the clinic, is that when the damage has persisted for a certain time, it causes a wound or injury, and for that you have to go for the treatment. So that's your sort of basic how we perceive pain. What do you call pain?
But two people with the same injury can experience very different levels of pain,
Right.
right? So how does that happen?
Yeah, so as, first of all, there's genetic differences, and also this neural structure that is transmitting information from the stimuli to the brain that can differ from human to human and can be shaped by your experiences. Certain form of pain, for example, an example that is often given, the ballet dancers, what they do is they literally dance for hours on their foot, right? And they're putting the entire body out on the foot. It's as such very painful. So and they wear this really tight shoes, etc., right? And this example is often given that they love dancing so much, even though it's so painful, that even women, when they get pregnant, they'll still continue practicing dancing. So they can motivate themselves and actually overcome that pain if one wants, and kind of makes it a pleasure. And of course, this is not harmful. They have taught their nervous system that it doesn't cause any harm, so that the alarm system doesn't work here. So what I mean by that is that your experiences and your motivation also can shape your pain thresholds and also your perception of pain.
So you're saying that pain is very context specific,
Yes.
if I can say that. Okay, so it's a very personal experience then. So Vimee, for something that is so personal and so subjective, how do doctors actually measure pain?
As a clinician, if I say, yes, it is very subjective, but for me to convert or visualize what the patient is going through, we use a lot of things in our clinical interaction. One of them is visual analog scale, which starts from 0 to 10, but definitely it is not the only thing which gives us. So it gives us 0 is the least pain and 10 is the worst pain they are experiencing. So patient has to tell us that, imagine that, okay, if this much is the pain, like what is her experience? So she'll score on 7 on 10 or 8 on 10, like that they tell us. But that is not enough. So we do ask them, what is the cyclicity of the pain? Is it regular? Or it happens only few times of the day? Or it is aggravated by something? Or it is reduced by something? Sometimes we also ask them that how it affects their day-to-day activities. Is she functional? Is he or she is functional with that pain or not? Can they do their routine activities or not? So all these things combined together, we try to visualize how this pain is impacting her quality of life. So it's very subjective, as you said, but it is very difficult for us to just stick to one scale and get an answer. So we use all these clinical things mixed with examination, and then comes the role of test. So this is how we assess pain in our clinical setting, and we try to interpret what is the suffering they are going through.
Otherwise, you are like asking people to simplify their entire experience into a number, and that's very difficult to actually. And it also has a lot of implications, I think, when pain is long-standing, when it's multifactorial, when there are different things. So, but is it a common practice that, across the board, is this how pain is measured?
Yes, there is no other scale. It's a visual analog scale which we show to the patient. We tell them that this is how the pain can look like. Because pain is not seen. It is not visible. It is not a tumor or lump which I can palpate and tell them, okay, do you have this much pain? You have mild pain, moderate, severe? No. So it is subjective. They have to interpret it and give me a scoring on that. Okay, this much is her pain. What she perceives. So for some patients, it can be 7 on 10. For some patients, the same kind of pain, 2 by 10. But we can't compare between two individuals. That is also very important, because as thresholds are different, And Dr. Barik already told her there is a lot of genetics involved, the biology is involved, so we cannot compare two individuals with the same scoring also. A person may tell 7 on 10, another one also 7 on 10, so how do I perceive it? I only know that it is severe. But then we have to ask them certain questions like, is it impacting their day-to-day life? One person with 7 on 10 may be fully functional and doing everything around. The other person with 7 on 10 may be immobile and not able to do any function at all. So there are a lot of factors which we take into consideration. It is not an absolute scale. We need to correlate with all other clinical things as well.
So some statistics now. Apparently, am I audible now? Okay. The statistics say that about 20% of adult Indians suffer with chronic pain. That's about 27 crore Indians. That's a staggering number. So Vimee, again, if I may ask you, from the experience of your patients, what does chronic pain actually, how does it affect their lives? And what are all the different ways in which it can actually sort of affect their everyday living?
Do I stick only to women or I talk in general?
I'm asking in general.
So in general, when chronic pain is there, definitely, one is whether it is diagnosed or not. My diagnosis is therapeutic for any kind of pain because it is, again, it is not a tumor or not seen. So when somebody tells us they have pain, whether they have been diagnosed, they have been validated, they have been believed, that is the most important thing. If they have been dismissed, the pain is going to aggravate and they're going to live with it for more years till they're diagnosed. So they have been validated or not, they have been diagnosed or not, the extent of suffering with this pain depends on all these factors. So there is a group of people who have been diagnosed with some disorder and they have chronic pelvic pain, they are addressed whenever they go to the clinic or they are heard. People around their workplace understand them. Then it has a different impact on their life. But there are people who are not heard, they don't have a diagnosis, especially I'm talking about a disease called endometriosis where there is a delay of diagnosis of 7 to 10 years. They don't even know that they have endometriosis, they keep suffering, they are told that you get married, you have children, you will be fine. They keep going to several gynecologists without getting any diagnosis. These patients or these people will have very bad quality of life. It impacts their work life, their career, their family life, and everything which is associated with them. So living with chronic pain is not easy, and then sometimes you need to prove it to the people around you. They don't believe that you have pain. You're skipping your work. You're not doing your projects on time. You keep telling them, okay, I'm not well. How do you prove it? So these are the things which come as a package to these people who suffer with chronic pelvic pain. And sometimes they keep showing up in spite of their health not supporting them. So first of all, we have to believe them, talk to them, diagnose them. Listening is the key where we can help them. And as Dr. Barik was saying that it is a language which medicine needs to learn to understand. So your body is telling you something. So if they are saying pain is there, we need to believe and take actions accordingly.
I'm going to build on that. So when it comes to pain, I think women are disproportionately affected, right? Do we know for sure that women suffer more with chronic pain than men? And if so, Arnab, what are some of the reasons for this?
So there have been several studies now that shows if you isolate or dissociate the neurons from an animal, right? And you take a male animal and a female animal, we're talking about laboratory mice here, they behave very differently. When you give a threshold, if you give a pain stimuli, the threshold of the neurons that are gotten from the female animal is actually reacting to a lower threshold. So, yes, so women have lower threshold, and that's sort of hardware genetically in your biological system. Now, and also there are some other evidence showing that prolactin and for women and orexin for men actually affects your pain thresholds, which we call it nociceptive threshold. That's a noxious stimuli, what you react to, right? So yes, women are differentially affected, and right now there is a lot of biology understanding behind it, and we know for sure. However, what we don't really understand, so the perception of pain and your thresholds are very different thing. What you suffer from, not from your threshold. Threshold is when you're reacting to it, it's hurting. But how do you cope with pain, or how do you withstand the pain? That is very different, and that is very poorly understood. I mean, there can be men who can cope with pain have much more difficulty in coping with pain. Women might be better, and there can be social reasons for it. But we don't understand actually how the brains of men and women are differentially processing pain. But for sure, there are biological evidence showing that our nervous system reacts very differently to painful stimuli.
Lots of, this mic is rolling. There are lots of chronic pain conditions which I think are more seen in women than men, right? Vimee, do you want to comment on that?
Yeah, so there are certain conditions which are found more in women, like migraines, fibromyalgia, some of the autoimmune disorders. And women-specific condition as endometriosis, adenomyosis, although they are women-specific, but even it affects male, the literature has shown that. So there are certain conditions which predominantly affect women. So definitely their percentage is more when it comes to the chronic pelvic pain or chronic pain in general if we talk.
Difference also extends into how care is given in our clinics and hospitals, right? I mean, do men and women get the same kind of treatment for the same reported pain? Do we have, I'm sure there are lots of studies out there.
I think there is a gender bias here as well. So if a male person reports a pain, definitely they get treatment faster, investigations are prescribed faster, and the diagnosis is also faster. But if women goes with the pain continuously to the doctor or to the family members, first of all they tell, and then they go to the doctors, and they're often dismissed. They are told that you have overworked, you didn't take rest, or you are just faking it, it's in your head. So they are prescribed medication later, they are dismissed to some extent, and these are the reasons the diagnosis is delayed for many of the disorders. Now, we always say, because I work in this space, endometriosis and adenomyosis, we always say that if it was a men's disease, it would have found a cure by now. Unfortunately, that's not the case. Because it's a women's disease, they're still fighting it hard. We don't have research funding. The government or the policy makers are not interested in it. We keep talking about it. So these are many hurdles because women-specific disease are not getting the attention it deserves.
Like, you know, some of this pain is very unique to women also, right? Like menstrual pain, pelvic pain. I mean, these are things that men don't experience at all. And unfortunately, in our society, these are very much normalized. I mean, girls as young as 9 years and 11 years are told that, oh, this is part of life, you just have to put up with it. I mean, how true is that, Vimee? I mean, is it normal? Should we just, is it just,
So,
you know, is it our fate that, you know, we're born women and have to put up with this pain?
Yeah, so normalization is the first, I would say, hurdle which delays the diagnosis. The pain is normalized for women at home, at school, college, workplace, and then the doctor's clinic as well. Every day I get patients who have visited 10 or 12 gynecologists who have dismissed their pain. And not only the family members, the gynecologists themselves have told them, go get married, have children, you'll be fine. So marriage and childbearing is not the solution to everything. So yes, women have endured pain. Teachers have told young girls that I used to have pain, you'll be fine. So some girl who went to their teacher and told that, ma'am, I have pain because she has started her period. So it happens, I used to have it. So this kind of dialogue, dismissing the pain if they are addressing it, definitely leads to long-term problems. And what happens is it leaves a huge psychological impact on that young mind. When she keeps telling her mother, keeps telling her teacher that I have pain and she's being dismissed. So what she does is she starts comparing herself with the other students in the class. They can manage it, I can't manage it. So that there is a problem with myself. So she starts doubting herself, the self-esteem comes down, the confidence comes down, because everybody of her age and her stature and her class, everybody can do everything during periods as well, but she's not able to handle it. So there is a problem with her. So normalizing pain is not normal at all. We need to delete that word normalization of the pain is normal. We should not never say that pain is normal. Pain is a signal. Just listen to it. And if pain is there, try to find an answer to it. So dismissing, gaslighting, and normalizing, we need to avoid that even in our normal conversations. If someone is expressing themselves, just listen to them. You may not have an answer to that, but don't dismiss them. Oh, it's okay, let's go, we'll do something else. So don't do that.
We talked a little bit about this already, but then I just want to spend some more time actually getting to the bottom of it. Whatever little we know of this, biologically, from the neuroscience perspective and biological perspective, is there any reason to dismiss women's pain at all? I mean, I'm just trying to sort of understand how men and women process pain differently, and also some of the biological safeguards that men seem to have against pain, women don't seem to have. That probably explains the sensitivity that you were talking about. So can we spend a little bit more time understanding this, please?
Yeah, so there is a kind of pain now which has been described in medical literature, which is called a nociplastic pain, which means that you don't have any peripheral symptoms. However, you are suffering from pain. Now, if you go to a physician, the physician finds it hard to really diagnose what has happened. So it is just what you were saying. There's, as she mentioned, that there's no way to measure it, right? So often it can be dismissed as it's in your mind. And some of these autoimmune disorders and also disorders like fibromyalgia, like pain symptoms, syndromes like fibromyalgia, which are often predominantly affects only women. And so it doesn't affect men for some reason. We don't know exactly what it is. Is it a nervous system disorder? It's an immune system disorder. We have no idea. And when you don't have a peripheral injury or a causation, it's hard to understand what is going on. So, and as I mentioned that these disorders, there's nociplastic, sort of also CRPS, like this affects women predominantly. So yes, there's absolute biological reason to think that this sort of pain syndromes can be completely dismissed. And these are body-wide pain syndromes. So, and even like fibromyalgia, often in the US it's a white woman thing, right? So it's not even diagnosed, it's not even believed to be true. But now, even in India, you will find several patients, so it's not a white woman thing. So hence, it's a real thing, but...
And how do male and female hormones impact pain?
So as I mentioned that there's some evidence now prolactin in women and orexin in humans, in males, affects actually pain thresholds, but I don't think that completely explains what is going on here. It might be, has to do something to with other physiologies, such as the immune system and the interaction between the immune system and nervous system. So, but we don't know really much about it at all. Right.
Okay, because I remember reading that somewhere, correct me if I'm wrong, that testosterone actually can act as an analgesic.
Yeah, so I mean, what do you mean by, so often when you do experiments, you're doing in an animal. So yes, there's some evidence, as I mentioned, orexin and testosterone can actually reduce, increase pain thresholds, but I don't think that explains this differences in a very severe disorder like fibromyalgia.
Okay.
Yeah, I think the causation is different.
Causation could be different, but I'm just trying to understand when it comes to the sensitivity of pain, could some of these things explain? Like, testosterone, if it is acting as an analgesic, and then I think there's a lot of research now also showing that estrogen receptors actually are very much part of the dialogue between estrogen and the nervous system and how it makes people more sensitive to pain and things like that. Right. So I'm just trying to see if how much we know about. Yeah, so the example I
gave you, so there have been tissue derived from monkeys, humans, and animals, and it has been found that only the neurons that are, or the nerves that are derived from this, only the female genders, if sexes, prolactin can actually affect so it makes sense that certain hormones that are only in women.
So if I can sort of summarize this then can we say that there are biological reasons to say that women suffer more with pain, and that is the reason why women complain more of pain. So this pain is real and it is not imagined.
Yeah.
Can I say that from whatever we
Yeah,
know of?
yeah.
Okay. And so we saw so far that, that there is more prevalence of chronic pain in women. There are also a lot of pain that is very unique to women, but still there is very little understanding of women's pain. Arnab, if I can ask you again, how much of this is because of the way research is done? Historically, women have been excluded from clinical trials, so how has that shaped what we know or don't know about women's pain and how women respond to pain medication?
Right. So yes, as you mentioned, historically, clinical trials, women had been not included. Even in animal studies, typically what would happen, so when you study pain in animals, like say mice or rats, they can't speak, right? So the only thing you can do is do behavioral testing. So that's why, and then already there is so much variability, and because of estrous cycles, we tend to always take out the females and do all the studies in males. But however, last 10 to 15 years, there has been a lot of stress on you have to include equal number of males and females in your study, or say that you have studied only male mice and you have not studied the female mice. So there is a lot of stress on it. I mean, like there's a lot of stress on this thing to include females, consciously include females in studies. Also, and as they have been included, now we are finding mechanisms that are very specific to male mice versus female mice, because now that progress has been changed right now. Sorry, anything else? I forgot.
That's fine.
Yeah.
I think I'm just trying to sort of, because I've read somewhere that actually women need higher doses of analgesics than men, for example, and that across many diseases, women experience more severe pain than, and I think all of these are very latest things, maybe
Right.
from the past 10, 15 years.
Okay.
So I think I'm just kind of trying to make a point here that, women make up 50% of the population, and I think it's so unfortunate that the research that we do is sort of not directly applicable to half the population of this world. And also all of these conditions that are, specific to women, it is still treated as a niche area. Funding, policy, all of this considers women's health as niche area, but then we make up half the population of the world. So I think I was just trying to sort of, get to that. And
Sorry. Just to add to that, so pain research itself has been neglected over time. Because it has been assumed that you give opioids, and everything is so the research is driven by the West. So they had neglected over time, and there is often pain is included as anesthesiology departments would go for pain treatment. There is no pain medicine department. However, what has happened is, so there is an opioid crisis in US. So what happened? The opioids were overprescribed, this oxycodone, and then a lot of people got addicted to heroin, etc., and people started dying. So as a result, suddenly there is a huge rush of pain research. So it's not just men or women, pain research has been neglected over years. With last 7 to 8 to 10 years, there has been more focus. In India, it's almost non-existent. You can count like 2 or 3 researchers in the entire country. So the funding is also very little. So there's a lot of work to be done, and of course, women's health. But I think as such, there's need for more pain research and access to pain treatment.
Sure. Vimee, your comment on this, you work in the specific area of women's health. So
as you mentioned, women are half of the population. Still, funding and research is lacking because they don't look at us as the birth giver to the next generation, including men and women. If they start looking at us like that, definitely we might get some attention for the diseases and funding. The moment we go to these policymakers to talk about this endometriosis and adenomyosis with all the data, we keep telling them this many women are suffering, 200 million worldwide, 42 million in India. But still, they don't want to pay attention to it. I still don't know what are the reasons behind it. That's what if we have to tell them that we, the women, are going to give rise to the next generation as well. We are the birth givers to the next generation also, including men and women, so that's the whole population. So maybe that will make an impact, but till then, men have to get endometriosis to get funding, I think.
There's some hope, I think, there, no? Compared to, last few years, I do see some more funding for some women-specific conditions. We have a long way to go, of course, but
Yes.
at least there's some recognition and hopefully it'll
Yeah,
get
I
better
think
with-
because of the awareness, because the conversations around this topic have started, women are getting aware of their condition. They have started talking about it. Earlier, they were told that hush hush topic, don't talk about periods, don't talk about periods related things. When the advertisements were played on the television, they used to switch the channels. Now, these things are not happening, that in the house also the conversations are starting. So, definitely, there is a change from what we used to see 5, 10 years back. I agree with that, but yes, there is a long way to go to get the proper attention, research, to find a cure for certain condition. We really need a lot of research and backup. It's not easy to do research in India until unless we have a government backup or a policy maker backup for a disease which is specific to one gender. So yes, we have a long way to go, but we need to continue these conversations. What we are doing today, it will make an impact, and we are going to do it.
Okay. Okay. In the interest of time, I think I'm going to want to spend the last section of this conversation talking a little bit about ignored pain and the consequences of that a little more in depth. And you know, the statistic that I talked about, you know, that 27 crore Indians suffer with chronic pain. Apparently, only 5% actually go to any specialist for their pain. And I think that tells us a lot about, you know, how we perceive pain as a society. I think in India especially, you know, as a society, we kind of think of pain as part of life, maybe even as like, you know, I don't know, test of faith or consequence of karma. And there's a very strong cultural expectation to suppress pain. And I think this kind of affects, again, men and women differently. So Arnab, I mean, this cultural conditioning that men have in the country, you know, how does it impact how they access care for their pain or for generally for their health when it comes to men?
Because pain usually doesn't cause mortality, right? It doesn't cause death. And hence it tends to be ignored. So if you talk about cancer or something, you will go immediately for treatment. But of course, that's required. But India, if you look at access to pain medication, India has improved a bit in the bigger cities. However, most of the rural population where most of our people live, they have no access to pain medication. There is nothing called a pain clinic in India. So, and if you look at users of opioids, India is one of the largest producers of opioids, but it's not accessible to us because the regulations don't allow us to access to opioids. Now, opioids can obviously, like something like morphine or fentanyl can cause addiction, but if they are like given with sort of physicians' approval and guidance, they can help you to a large extent. So access to pain treatment is still severely lacking in the country, even though we suffer from as much pain as anybody else in the world. And also the financial sort of conditions dictate how much access we have. The government has to have better regulation and also pay attention to it, even though it doesn't cause mortality, but it reduces quality of life. It can cause mental health issues. It can cause loss of productivity, cause stress and anxiety and depression. So it's an important thing to be taken care of. Yeah.
Any, I don't know, data or statistics on, you know, this sort of, especially related to India and this sort of cultural conditioning? I mean, I think all over the world we have this thing, right, that men basically shouldn't complain as much, or like this macho image that we have for men that sort of, does it really impact, in your, I know you are a scientist, so, but because you're a pain researcher, you probably read a lot about how people actually access treatment. So I'm just trying to sort of understand if this, in India specifically, you know, do we see that difference at all, that men come late to access care because of this, or is that just something that
I think that plays a role, and globally, like, you know, as a man, you are supposed to suppress pain. However, as I mentioned, that pain is just a signal. It's just telling you something is wrong. Often it's localized in the sense that it tells you from which part of the body it comes. So if you go to the physician, they can actually start looking from there. Sometimes it's generalized, like you don't know, it's your whole body is hurting, right? Like something actually in fibromyalgia. So the thing is that it's just a warning signal. It's nothing good or bad. But of course, the cultural and the social phenomena, like, you know, sort of phenomena dictate how we access to pain.
talked about the additional layers of social and cultural bias when it comes to women. But Vimee, again, from the experience of your patients, I just want to understand, we talked about it a little bit, but I'm just trying to sort of understand a little bit more the impact that this ignoring of pain does to the patients. In the sense that, can we just wish away pain? By ignoring pain, can we sort of hope that it will go away and then things will become normal? Or does it actually make it worse for the patients that you treat?
So basically, ignoring pain and dismissing, I already have mentioned about it by an example of a teenage girl, like how it impacts their life. So similarly, for any age group women, if we are dismissing the pain and not diagnosing it, then again she starts into the vicious cycle of disbelief. She starts doubting herself. She tries to cope up with all the functions she has to perform, and she tries to keeps doing it till she endures it. So she does not come up again and again, because every time she comes up with that, we are dismissing her. We are telling her it's not there. It's in your mind. You're faking it. So then it affects her mental health, social health, her relationships, her marital relationships, as well as family. Everything gets affected, career, work life, and sometimes they lose their jobs as well. And promotions are also at stake for these women who are not diagnosed, and definitely the workplace is not very conducive to these things, which is not seen. When they don't have a diagnosis, what do they go and tell the employer that they are suffering from something? So this have long-term impact on their overall health, mental health, and once the mental health is affected, everything gets affected, be it family, social life, or anything. So this dismissal of pain needs to stop. We need to show up. If we have a problem, let's talk about it and try to find an answer rather than shooing it away and telling them, no, nothing is there. And every age group similarly gets affected. Like a teenage girl they will have a developmental problem because they develop with that disbelief. And ultimately, they stop believing the healthcare system as well. They stop going to the doctors. Many women, they come to me, they tell us that we have already visited the doctor, and every time they told nothing is there because the scans were showing normal. So there are many disorders which may not show up on early scans or imaging, or sometimes the expertise is not available. Now that's an altogether different aspect of discussion which I can't bring in here because of time constraints. So there are lack of diagnosis because of lack of experts as well. So it's not only family, society, culture which is dismissing it. There are a lot of gaps in the healthcare system also which are delaying the diagnosis and not addressing in time. And then they have a long-term consequences because the disease is progressing. Whenever I'm referring these things, they're particularly to that condition, which is endometriosis. So that disease is a progressive disease. It damages the organ. It affects their reproductive function. It also affects their kidneys and vital organ function. So I give you an example. One lady came in teenage years to a gynecologist, and she was dismissed that pain is not there. It's fine. She took some painkillers and managed it somehow. She grew up. The pain was also growing up. Then when she got married, she went for checkup, and then she was not conceiving. They diagnosed her as endometriosis, but then they did not diagnose fully. And they told her to conceive. Once you get pregnant, you will be all fine. And she tried and tried. She could not conceive. And after 3-4 years, they went to an expert, and then they diagnosed that there was already an obstruction of the ureter, and she had lost her kidney. Had they diagnosed it 10 years back, we could have saved her kidney. So losing an ovary is still acceptable, but losing a kidney is not acceptable. So there was a signal at that time when the first time she went to the doctor. So yes, the collateral damage is huge if we ignore, if we don't diagnose, and we don't address it on time.
And Arnab, neurologically, what happens when pain remains untreated for long periods of time? Does chronic pain actually change the nervous system?
Yes. So our brain is very plastic, which means that everything that we experience actually shapes the next experience, right? So same thing with pain. So if you don't get your pain treated, or the cause that is resulting in pain, if you don't treat that, the disease that is causing that, or the disorder, the defect is getting worse. You are not paying attention to it. And the nervous system is also getting sensitized, which means that your threshold will go lower and lower, and eventually you will withdraw yourself from the society, from your surroundings, if you don't want to work, and you don't want to see, like, a basal level of anxiety is good for you. That's how we interact with the world. Like, you study in a class, or you prepare for interview, you become hyper anxious, so you don't want to deal with that. Often people leave jobs and they sit at home. So yes, like, if you have your pain untreated, or the cause that is causing the pain untreated, and also what is called as pain management. So often the pain cannot be cured or completely gone down to zero, but you can manage the pain using drugs, or using therapies, physiotherapy, using exercises, etc. So if you don't take care of that pain, it is going to affect everything else, and can take severe toll on your physical, mental, and social interactions, etc., and profession.
I think that's very important for us to know, especially in our society where, like I mentioned, we have this, we tend to sort of suppress cultural expectation to suppress pain, but what we're actually doing is actually damaging our own health even more, and then making ourselves more susceptible to even more pain, because it also kind of becomes more decentralized, and then they don't know what the cause is, and then it all just gets very confusing and very difficult to treat. And I think we kind of on time here. Just maybe one last question, Vimee. As a clinician working in this area, what do you think needs to change about the way medicine is practiced today to sort of counter some of the things that we talked about today, especially when it comes to ignoring pain, dismissing pain? What needs to change in the way we are doing things right now? And how do we make people feel more heard and supported when they're suffering with chronic pain?
One is we might need to unlearn few things. Like we need to unlearn not to dismiss others. And as a clinician, we need to unlearn that normal reports does not mean there is no pain. So there are, most of these patients, they come to us, they come with a normal imaging. And they say that a doctor has told that nothing is there, so you're all fine. So we need to unlearn that fact that normal reports does not mean there is no problem. So reports do not guide to the diagnosis. It's a lot of things which we take into consideration. And for public and a lay person, I would say that dismissing others and not listening to them and telling them you are faking it, we need to unlearn that. We need to tell them not to do this. And pain is not normal. That we need to spread the word that pain is not normal. When pain is there, it's a signal. Just listen to that and seek an expert help for that.
More time, or should we? Okay, yeah. So we'll take some audience questions now. Mics. Huh? Yeah. Oh,
can I ask?
Yes, yeah. Hi, Rakesh. Yes,
Hi.
please.
So it's wonderful. So I mean, you discuss many social aspects of it. My question is more scientific and biology related. You said women have lower threshold, and females have lower threshold even in other animals, and probably that is true for humans as well. Do you think there is any, but it looks like it's, so men are at disadvantage because you don't feel something is wrong, but you are not able to perceive it. So what is the evolutionary advantage of having a higher threshold of pain signal?
I don't want to comment on it. I don't want to speculate, but yes, like what do you mean by nociceptive threshold? It means literally the temperature that you will react to. That's all, right? So it doesn't really translate into how you cope with pain or how you bear pain, like what sort of we perceive or you perceive pain. It's just the threshold. Like it will be like, if you give a heat stimuli, the seconds it takes to react, it's shorter in women. How does that translate to actually bearing or coping with pain, like men versus women? I don't know. We don't have much evidence, but it's different. Like,
Doctor, I have a question for you from a rural background. So like still after years of independence, 70% of population dwells in rural, and most of the livelihood things contribute to this chronic pain, especially in women. They just not do their agricultural work, but also regular domestic work, which is very labor intensive. And very rarely we see that, she's given the credit to be a she farmer. And with this, with the socio-economic burden, there is a lot of pain, just not endometriosis, but also spondylitis, a lot of other things, which starts from her teenage and ends up to her last age of life. And so, like, as a public health person, I have gone and met doctors at the PHC level and also at the rural hospital, but they don't have the facility for physiotherapy like we do have in urban. So what do you think that are the key takeaways for such population? What they should be doing and how we can address the issue in the rural area? Thank you.
So it's a very good question because it also reflects on the healthcare services being provided to our population. So there is a lack of these facilities in the rural areas, I agree with you, and definitely those patients will never come to us because of lack of affordability, financial status, and they don't have time as well because they earn daily and they eat daily. Am I correct? So if healthcare can be provided at grassroots level, then only it can be solved. There is no other way to solve this problem because these patients definitely will not seek care. They keep suffering, they keep doing their work because their daily bread comes from that. We cannot tell them, you don't work for 2 days, you take rest, you do go for physiotherapy session, travel for 400 kilometers and get the pain relieved. She will stop talking about the pain at all. So it's the primary health centers where we can provide these facilities. The government policymakers have to pitch in, definitely raise awareness among them, because you will live longer if you're healthy and you will earn more, you will take care of your children more. So this is the kind of education we have to give to those people as well. She is not asking for care. We are recognizing it, but she is not asking for care because she is not aware of it. She says, okay, it's fine, I have to suffer like this, I'll keep doing this, and then I'll earn daily, I'll feed my children, I'll sleep. This is what her life looks like. But she doesn't know that her life can be better if she doesn't have pain. So we need to educate them, we need to tell them that this is your right and you can ask for it. And then government definitely has to come with a policy and something which is available to their place, not that she has to travel some far distance and get the relief. And she has not asked for this relief. We want her to get it so that she experiences it. So there is a difference where when you ask for it and when we tell them that you need it. So until unless she experiences it, she will not know it is better. So she thinks it's a way of life, it's normal, and she's carrying on with her life.
Yeah. Speaking of unacknowledged pain, and Karnataka has introduced this one-day menstrual leave every month for women precisely to deal with periods. And of course, that's had a whole lot of debate and kickback and women won't be hired. What are your thoughts on this decision? I think it's great, but what do you think about this decision?
It's great, no doubt about it, until unless it is misused and not used, because many a times these things are misused in our population rather than utilized properly. There are many women who really need leave on first or second day of their periods. Sometimes they may not have chronic disability, but the periods sometimes may cause so much of fatigue that they can't do anything. So if they are given rest on that day without any judgment and looking at them like this, oh, you are in periods, so you don't do anything. So that kind of thing will not come, and that's a great move actually if utilized properly. If our people don't, for social functions, they apply this leave, and then they have a period, then that's wrong. That should not come up. Definitely 1 day of leave a month on first day of their periods, they can avail paid leave. That's a great move actually. Really people who have chronic pain or pelvic congestion syndrome or endometriosis, adenomyosis, they struggle to get up from their bed. It's very difficult for them to get up and they have to apply leave every month for 2-3 days. So it's a great move if utilized properly, definitely. And it should be implemented all throughout the states. There is no harm. And in compensation, if men has a problem with this, maybe they can work on a Sunday or something, compensatory work they can do, but let them give a leave.
One question there.
So I have a question about managing pain. So we tend to take painkillers if it's too much to handle, but at the same time, you know, when you think about pain as a signal that something is not right, and by numbing that signal, you might be doing more damage sometimes, right? So, I mean, the body adjusts to, okay, I take a painkiller, I go do my work, I come back, I rest, and, you know, you kind of manage, and that balances over a few days, I guess, you know, maybe things get better. But I think it's about when should you not take painkillers, because sometimes you're aggravating something, or is it dependent on the kind of pain you have? And of course, not to become dependent on painkillers and addicted to it, but how do you, where's the balance?
No, it will depend on disease specific. Suppose you have a migraine and medication is the answer, definitely you will take medication and that's absolutely fine. But if we talk about pelvic pain and you don't have a diagnosis, then there the collateral damage can happen to other organs. There it should raise an alarm. You're popping 3-4 painkillers during periods every month, skipping your work for 3-4 days every month and not getting a diagnosis. There, this should raise an alarm. But if you have a headache or if you have a body pain which subsides with a simple painkiller, that is fine. But if it is recurrent, coming again and again, not subsiding, you should seek expert help. So popping painkillers during periods every month, more than 2 to 3 in a day, definitely is not normal. So there is a signal where you should intervene and find a diagnosis. If you have a diagnosis and there is a medical treatment your doctor has advised, you can continue with that. There is no problem. But then you are self-treating yourself, over-the-counter medications you are taking, then definitely it's not correct and you need intervention.
When is it that I have to go to a doctor? How much of
So
pain
there
is
are two
manageable?
types of dysmenorrhea, primary and secondary. Primary is when there is mild cramps, there is no underlying cause. Secondary is when there is a cause. So primary dysmenorrhea usually is milder cramps, subsides with a simple oral over-the-counter analgesics. But definitely doctor should examine you and prescribe you. You can do your routine activities, you don't use hot water bag, it's fine. But if you're using hot water bag, simple painkillers are not working, you cannot get up from bed, you cannot do your routine work, you need attention and you need to seek expert help.
Really running out of time, but I do want to give men in the room a chance, so I'm going to ask him to go ahead with his last question before we wrap up. Yeah.
So just a question. Initially, you said that pain is subjective and it's not very easy to measure. So are there any research being done into specific biomarkers or neural signatures which can objectively measure pain?
Research is going on, but then it's still not a very conclusive research has come. So as of now, clinically what we measure, suppose a patient comes to us, we measure a weight. Like that, we don't have any scale for pain. So it's a subjective pain perception which patient tells us, but we need to correlate it with a lot of other things which I already mentioned, that we need to examine them, we need to talk about the cyclicity, aggravating factor, relieving factor, type of pain. They describe the pain. Like endometriosis patients, sometimes they describe it as burning. Something saw is cutting their abdomen. All these pains, she's walking on a barbed wire. Like this, they describe the pain. So this is what gives us the perception what they go through.
Need to wrap up now, so I think I'm just going to close, I think, by saying that we've kind of heard that, you know, while modern medicine is very, very good at measuring disease, probably not so much at understanding pain yet. So I mean, if we take the lived experiences of people, you know, as useful information rather than as anecdotes or exaggeration, I think we'll do a lot better at understanding pain, both in the clinics and also in the labs. And if conversations like this can help, you know, take people's pain a little seriously, a little earlier, I think that's already meaningful progress. So that's a thought that I would like to leave with. And thank you so much for joining this conversation.